conversation focuses on the evolving Medicare and Medicaid coverage for anti-obesity medications, particularly GLP-1 therapies, and how the Centers for Medicare and Medicaid Innovation, or CMMI's, new bridge and balance models are shaping access for older adults. We aim to help healthcare providers understand both the policy and practical implications for prescribing these medications alongside structural lifestyle support. I'm delighted to be joined by Cristine Gallagher, coordinator of the Obesity Care Advocacy Network, or OCAN, who brings us expertise in patient access, policy navigation, and obesity care advocacy. Welcome, Cristy, and thanks so much for joining me today.
Thank you so much for having me.
Cristy, to set the stage, can you walk us through the core differences between the Medicare GLP-1 bridge model and the balance model?
Sure. Originally, the administration came out with what they called the balance model, which is actually CMMI model that would cover obesity medications, specifically GLP-1s, for those on Medicare, as well as an option for states to cover GLP-1s under their state Medicaid programs. That model was supposed to start in January of 2027. However, it needed 80% of the lives covered under Part D plans to be signed up for that model to move forward. And they weren't able to get all of the big, large Part D plans to sign up for it at this time because they felt like they didn't have enough information. And so they decided to delay the start for the Medicare version and instead extend what they were calling a bridge model. So the bridge model originally was going to be from July 1st to the end of this calendar year, 2026, but they've extended it to the end of 2027. So they'll have a good almost 18 months of data that they'll be able to use to help make the decisions for how they want to move forward and hopefully to convince the Part D plans to sign up for this benefit, and the balance model in 2028 would be when that would start. So the bridge model really is a CMS model. It's done under the 402 authority that CMS has. And so it'll be a program that will actually lay over on top of the beneficiary's already Part D plan. So if you're signed up for a Part D program under Medicare, you will continue all of your drug prescriptions and everything like that will still continue under your Part D plan. But then if you are able to get GLP-1 prescription and the prior authorization to be able to have this medication and have it sent to you, it'll be a completely different program. You will go to the pharmacy, you will pick up your prescription, and you will pay your $50 copay.
Historically, Medicare Part D has statutorily excluded weight loss medications. How do these new models bypass or shift that exclusion for older people?
That's a really great question. So one of the ways that they are able to do this is by the fact that these are actually demonstration models. And so we have the CMMI Demonstration Authority as well as the 402 Demonstration Authority. And so by saying that these are not going to go to sort of everyone and that they are also considered obesity medications rather than what was determined. Part D was originally passed in the early 2000s where it said that weight gain or weight loss medications were not allowed to be covered because they were seen as cosmetic medications. So they basically are now saying that these are obesity medications and therefore they're able to cover them under these models.
Because the balance model is a year and a half from implementation, let's really focus the rest of our discussion today on getting providers ready to participate in Bridge, Cristy. What are the clinical attestation requirements a patient must meet before the provider can prescribe a GLP-1 under the Bridge model?
So the way that we understand that this model will work is that a provider will send a prior authorization into Humana, who is the payer that will be running this whole model for CMS. And the provider will need to say that the patient has either a BMI of 35 and above, or that they have a BMI of 30 and above, and at the time of initiating the therapy, that they have either heart failure, uncontrolled hypertension, or chronic kidney disease, stage 3A or above. The other category is if you have a BMI of 27 and above, and you have prediabetes, or previous myocardial infarction and previous stroke or a symptomatic peripheral artery disease. So those are the categories. You also have to be 18 and above, but obviously for Medicare, that is usually the case for people. And then once the prior authorization goes through, then the patient will actually get their prescription from the pharmacy. And so that is about the extent of the details that we've gotten so far from CMS. We're expecting some additional details to come out later in June, hopefully, so that it'll be easier for providers to be able to work through this process.
Great. And then how about structural lifestyle support with the bridge model? What qualifies then as an approved lifestyle program? And how can primary care, who is busy and lots to do in a short visit, how can they realistically track and document patient engagement with that lifestyle support?
So also under the conditions and clinical criteria, it does say that the patient should be having current and ongoing lifestyle modification including their nutrition and physical activity consistent with the FDA approval. And so one of the ways that we have been talking about this is that it's really important for providers to have this counseling time with their patients. This counseling, also known as intensive behavioral therapy or IBT, is a Medicare covered benefit if it is provided by a primary care physician or in a primary care setting. And so it's really important for those providers when they're talking with their patients to discuss these lifestyle indications and benefits for the patient, talking about nutrition, talking about consistent exercise, talking about keeping their muscles strong, because when you take these medications, there is a risk of having some muscle loss along with the fat loss. So they encourage weightlifting that's appropriate for the patient, that kind of thing. Also, and it's really important to have appropriate protein intake when you're taking these medications. And also, if it's the first time that the patient has taken the medications, it's really important to talk about the side effects that might go along with them. And we don't want to see providers who are writing prescription and then waiting 6 months or so to see a patient, because it's really the side effects can be intense, but they can also be short. And so it's really important for the patient to know that, I might not feel good for 48 hours after the first injection, for a couple of weeks, and then my body gets used to that. And what are the things that I need to do in order to make myself feel better during that time? And also eating crackers first thing in the morning, or the other things that you would do to take care of your body when you're taking a new medication that has these side effects.
How does the $50 copay mechanism work, so to speak, and as far as documentation, billing codes, other prior auth steps that providers need to be aware of to make sure those medications are approved rather than denied?
Yeah, so this is one of the areas that we are a little bit concerned about for some patients. So the $50 copay actually sounds great on paper. Patients will be able to get these medications for $50, which is a lot less than if they were buying them directly from either the company or from the pharmacy and paying the $1,000 plus that we've seen advertised. However, because this is a program that is run by CMS and is not part of their Part D benefit, it is a $50 copay that will not be applied towards their deductible for the year. And it is also excluded from some of the programs that are out there to help lower income older Americans with paying. And so that is one of our concerns, and one thing that we would like to see better under the balance model. And we think that balance model will be able to help that, because the balance model will actually provide these medications through their Part D plans, and therefore any copay will go towards their deductible for the year.
Great. So thinking about older adults, what practical steps do they need to take to access the GLP-1 medications under the bridge model?
So I'd say the first step would be really thinking about whether this is a medication that will help you as an older American or an older adult to be able to reach some of your healthcare goals later in life. And then to have that conversation with your provider. So these are difficult conversations sometimes to have, because you're talking about weight and you're talking about living with obesity. And so sometimes patients don't feel really comfortable. So make sure that you have a provider that you that you feel comfortable having these conversations with. Bring it up with your provider. Ask if you are a good candidate for these medications. Let them know what you know about the bridge model in case they may not know that this is actually available. Let them know that you know that it's covered and it will be covered for quite a while and that this is something you'd like to start and try. There's several different medications that are available and covered under this model. So it's not just one, it's Wegovy will be covered, the new Wegovy pill will be covered, Zepbound is also covered, as well as the new pill that Lilly came out with called Fondeo, I think is how they pronounce it. And those all are great options and they all have different benefits and they have different side effects and different things. So have that conversation with your provider. Also, maybe talk with your family members about this. If this is something that you've been thinking about and you want to try, let your family members know so that they can support you in this effort. And then make sure that you are following up with your provider after you've tried the medication out. Don't wait too long. If you feel like you want to quit, maybe make an appointment with your provider and have that discussion with them. It might be that you aren't right for the product that you've started, but you might be right for a different product.
Great. Looking ahead a year and a half to that balance model, what changes might providers and patients anticipate?
So this will be one of the ways where we really will need to have providers informed about the balance model because they will need to, if they have been signed up and under the bridge model and taking a GLP-1, they'll want to make sure that when they sign up for their Part D plan that starts in 2028, that they are signing up for a plan that does offer these medications. So you might need a switch plan. So that's one thing to pay attention to in the future. And we will have lots more information about that when the time comes. The other thing that will change, like I mentioned, is that copay or how that copay is applied to their healthcare spending for 2028 will also potentially change. So those are things to look out for. For the providers, I believe what will happen is rather than going through Humana as the payer that will figure out the prior authorization and so forth, they may need to send a new prior authorization form to whatever the patient's Part D plan is at the time. So there will be some changes. Hopefully, they will all run much smoother than they would have if we had tried to rush this bridge program through in 2026 and then switched over in early 2027 to the balance model. This gives us a lot more time to plan.
Great. We're coming to the end of our time together here, so I have that one big question yet, and that is, what haven't I asked you that's important for primary care clinicians to understand about GLP-1 therapy access and the CMMI models?
I think for providers, it's just really important to make sure that you're up to date on all the science around the GLP-1s. There's a lot of information out there. In fact, I spend usually most of my morning going through the news clips of all the things that have been written about GLP-1s in the last day or in the last morning. And there is a flood of information out there. I think staying in touch with your national association that you affiliate with the most, staying up to date with information that's coming out of the Obesity Medicine Association, the Obesity Society. Sign up for the Obesity Action Coalition. They are a wonderful patient advocacy organization that has a ton of information about obesity and about obesity treatments. And so just staying up with the science, because there's a lot out there and not all of it is definitely scientifically based or true. And so I think that's really important. Also, be open to your patients as they come to you. Again, like I said before, this can be a scary conversation for a patient to have with their provider. It's also sometimes providers feel uncomfortable bringing it up with their patients. So if you have a patient who you've talked around this topic before, maybe this is the right time to actually open up the conversation. Say, is this a good time for us to talk about your weight? I have some tools that are available and I would love to talk to you about this. If this isn't the right time, maybe you can make an appointment and come back to see me and we can talk about it further. This just really opens the door more for providers, patients, whether they are older adults or folks that get their care through Medicaid. this is a really wonderful opportunity for more people to have options and to have those conversations.
Thank you. Miss up here mentioned the GSA Care Toolkit for the management of obesity in older adults, alluded to some of the important aspects of with nutrition and fiber so important and exercise and all of this really need for interdisciplinary care for older adults. Highlight that in that free online toolkit. So thanks so much, Cristy, for joining me today, for sharing your expertise and such practical information. You've provided us with some clarity on how clinicians can navigate these new models and expand to care for comprehensive care to older people. It's really an exciting time. And to our listeners, thanks so much for joining this episode of the GSA Momentum Discussions Podcast. Thanks so much, Cristy.
Thank you so much for having me.
Explore the GSA Gerontology Resource Library at geron.org/library for toolkits, reports, webinars, podcasts, and other educational resources.